All right, I think we will go ahead and start. We have a number of people already joining us. So the title of today's round is Endovascular Treatment of Carotid Cavernous Fistula. A few housekeeping rules. Please mute your microphones unless you're speaking directly. If you're sharing a video, please be mindful of what is in your background. We've been able to proceed with very few technical hiccups, but if they do occur, please just give us a moment to work out. There'll be opportunity to ask questions at the end of the presentation. So you can put your questions down in the chat box during the course of the presentation. But if you want to ask directly, then that option will be available during the Q&A session. So unfortunately, Dr. Jagadisan will be unable to join us today at very short notice. So we couldn't make the alteration in the poster, but the presentation will go on, and Dr. Uchenna Okafor will be delivering the presentation today. And I'm sure Dr. Okafor is well known to those of us that have been at the previous ground rounds. He's the brain behind the sessions we've been having. He's a neurosurgeon and the co-founder of the West African Stroke Initiative. He completed his endovascular surgical neurointerventional fellowship at the Mallinckrodt Institute of Radiology at the WashU in St. Louis. And he also completed another endovascular surgical neurology fellowship. He had previously completed his neurosurgery residency at the Royal College of Surgeons in Ireland, and is a fellow of the Royal College of Surgeons in Ireland. He's also a fellow of the European Board of Neurological Surgery. He has both trained and practiced neurosurgery at the Cork University Hospital and Beaumont Hospital in Dublin. And he has also worked in several centers in the UK as a specialist, as registered specialist with GMC. He completed his medical school and received his MBBS from none other than the Nnamdi University in Nnewi. So we're going to have Dr. Okafor present to us, and then after that, we will take questions. Over to you, Dr. Okafor. And thank you for stepping in at relatively short notice.
Good afternoon. Thank you, Dr. Bankole, for that kind introduction. Like Dr. Bankole has said, we really apologize. Dr. Jagadisan had to step away and is unable to take the presentation. But I know that this has been heavily anticipated for the last 2 months when we brought out the notice. But these things do happen, emergencies do come up. So I have decided to make sure that we still take the presentation as scheduled. All right. So without further delay, we are talking about carotid cavernous fistula. Can everybody hear me? Can everybody see my slides?
Yes, we can hear you. We can see your slides.
Thank you very much. I believe this is a very interesting topic to talk about. Before we dive into the subject, we here in the US just experienced a solar eclipse that's been going around. I think the next port of call is going to be in Europe in 2026. It was a sight to behold, where the moon pretty much completely covers up the sun, as it orbits around, goes around its orbit, obstructing the light rays to the Earth. It was a beautiful sight. And I think the next time we're going to come to the US will be in the next 20 years or so. So I don't know whether we see it from Nigeria, but I know Europe is the next port of call in the next 2 years. Right, so going back to the subject, carotid cavernous fistula. I believe that this is a condition that was somewhat very, very frequent in the past, especially for patients that were involved with road traffic accidents before the advent of airbags, where it became a requirement for everybody, at least here in the US, to put on a seatbelt and airbags were mandatory for all cars in case of, terrible either rear ending or a terrible RTA or MVA, motor vehicle accident, that, it prevents one from lunging forward and hitting, their head against the dashboard and causing a direct traumatic injury that can, of course, cause a laceration in the skull base and, of course, cause a cavernous carotid fistula. This clearly is a picture of a patient who was involved in an RTA, and within a period of about a couple of months, began to notice a bruit in their head, loud sounds in their head. It wasn't psychiatric, so don't please refer them to the psychiatric hospital, Arrow Hospital, the mental institution, to get checked out. It was real. He had retroorbital pain. There was loud sounds in the head, and then slowly but surely there was proptosis. There was the gross nature of the eyeball protruding with a conjunctival eversion. There was ophthalmoplegia, cranial nerve 6 palsy, and it was pretty a grotesque sight. But you wonder, was this caused by evil spirits? Was this a person who needed to be referred to the psych hospital? But no, fortunately, he was seen by ophthalmology and had his non-invasive imaging that was suspicious, of course, of a carotid cavernous fistula, direct in its, we'll talk about the types later, and then eventually got his treatment. And after treatment, endovascular treatment, within a week, the eyeball, all the swelling had resolved, everything returned to normal. I don't have the post-treatment pictures, and he was back to normal with no more noises in the head. So we find that the piano people that will come across it, I'm sure we're going to open this up to conversation later on. I'm sure we have our ophthalmologists in the house, as well as our neurosurgeons, of course, neurosurgical colleagues who are here. I wonder what the incidence is in our part of the world, there in West Africa, which of course constitutes the most audience today for this conversation, or whether you've diagnosed, have you come across this in your practice? And I do know that one of our doctors, hopefully they can share some of their slides, is currently dealing with a case right now in eastern part of Nigeria, and is wondering how we can get that treatment done. So let's carry on. We're going to just go through pretty much, initially, we're going to just talk about a brief introduction on the subject. Now, the carotid cavernous fistula pretty much can be described or defined as an arteriovenous connection between the ICA, internal carotid artery, or ECA branches, and veins of the cavernous sinus. That's pretty much a definition. Now, the Barrow classification for this is either direct or indirect. Now, the direct type A is really what we refer to as the traumatic or direct carotid cavernous fistula, the ones we're used to, the ones where people on a motorbike, they're not wearing helmets or scooters, and there's this, sudden stop and they lunge forward and strike their head. So there's a connection between the internal carotid artery or its branches, either from the petrosal segment or the cavernous segment, and veins of the cavernous sinus. Now, etiology for the direct fistulas, carotid cavernous fistulas, will be trauma, like we've emphasized, or it could also be due to a rupture of a pre-existing cavernous carotid aneurysm. Most of the time, we know that we don't treat these aneurysms. Cavernous carotid aneurysms, we just watch them, and they rarely hemorrhage. They rarely, because they're extradural. That's why we don't treat them. They're not in the subarachnoid space most of the time, except it has breached the diaphragma cellae. But in times where they're large and they're growing, they can actually cause a CC fistula because it bleeds into the cellar compartment, which is just the lateral compartment surrounding the pituitary gland on either side. Other times when you can have this occurring is patients that have, especially the elderly women in their 60s and 70s, people that have connective tissue disease, and either Ehlers-Danlos or some kind of connective tissue disease where there's spontaneous rupture of the ICA in the cavernous segment, and that of course can cause a CC fistula. Now, the second classification, the Barrow classification, is the indirect CC fistula. And that's the one that pretty much is categorized as a true dural arteriovenous fistula, meaning that it's not like a transmural tear or hole in the cavernous, in the ICA, that's pretty much just pouring directly into the cavernous sinus that's adjacent to it. But this is more like connections from branches of the ICA or ECA branches, external carotid artery branches, that form true direct arteriovenous fistulae with the cavernous sinus, the leaflet, dural leaflets of the cavernous sinus. So that's either classified into type B, C, or D. B is when it's branches of the ICA, either the meningohypophyseal trunk branches or the ILT infralateral trunk branches that cause, this, early venous drainage, where you do the angiogram and you see early venous drainage, you see a vein, lighten up when you are still in the arterial phase of the angiogram, and it's within the cavernous sinus. That's a true or indirect type B CC fistula. Type C is when it's only branches of the ECA communicating with the cavernous sinus and causing this dural arteriovenous fistula. And type D is when it's both ECA and ICA branches at the same time. In my practice during fellowship, we came across a couple of them. Well, I'll have a couple of pictures to show you from textbooks. So I didn't save those pictures, but I'll talk through some of them as we go along. And the ones I've come across is mainly the type D, where it's both ECA and ICA branches that contribute to the fistula, the dural arteriovenous fistula, the CC fistula. And then sometimes, of course, rarely do we see the direct type A CC fistula. So as we move along, we want to just think about what are the indications? What should prompt you treating this condition, first of all? We'll talk about how to diagnose them, non-invasive imaging, and the gold standard, which of course is a 6-vessel diagnostic cerebral angiogram. But you find somebody's eye, there's increasing proptosis. There's a loud, audible bruit. You can put the diaphragm of the stethoscope and you put it over the eyeball, and you're hearing a whooshing sound. That's not normal. Or somebody comes with a diminishing visual acuity. Everything in the anterior chamber, posterior chamber, the retina, it seems okay, but there's depreciative visual acuity. Or maybe, of course, there's something that clues you in, which is a recent trauma. Or elevated ICP, or evidence of venous hypertension, which of course will cause a raised ICP. Patient is vomiting, complaining of headaches, retroorbital pain, or on imaging, you notice, let me just go back. On imaging, you notice an extension of the pseudoaneurysm or cavernous carotid aneurysm or venous varix from a cavernous sinus into the subarachnoid space. Sometimes a breach of the bone itself into the sphenoid sinus. And sometimes somebody present with massive epistaxis. And that's because there's been a breach of the floor of the sphenoid, and there's probably a cavernous carotid aneurysm has been undetected or undiagnosed probably, or who knows, been diagnosed, and it's protruding directly into the sphenoidal sinus. And ENT is there trying to do their thing, and it's just a CC fistula you might be dealing with. That's why you need to do imaging. And there's a direct connection between your ICA internal carotid artery with the cavernous sinus. So you need to check. Or there's been, you do an imaging and the person has ruptured, there's a subarachnoid hemorrhage, and you're wondering, what's the cause? Imaging is important. All right, so let's just back up a little bit and let's talk about some of the anatomy just to get ourselves well situated with the anatomy we're dealing with. Now, the cavernous sinus anatomy itself, this is the area of the cavernous sinus, all this area, right and left. It can be described as a plexus of veins contained with an extradural anatomical space lateral to the sella. So it's lateral to the ICA, the pituitary gland in the middle, IC on both sides, on either side. And of course, it's an extradural compartment. So it doesn't communicate with the subarachnoid space. It communicates with the spinal canal, but not with the subarachnoid space. It's not a single venous lake. There are multiplexes of multiple veins and discrete drainage patterns within the cavernous sinus. And of course, this overlies the sphenoid, the floor of the sphenoid itself, the greater wingos sphenoid. Now you'll find here, this is a nice diagram. I kind of like this diagram. This kind of gives an idea of what's going on, the inflow and outflow of the veins. Now, the veins, of course, that drain the head and neck of the head. You'll find here that anterior inferiorly, we have the superior-ophthalmic vein that drains directly from the eye, directly into the cavernous sinus. So it's anterior inferior, going from the eye backwards to the cavernous sinus. And then you also have the inferior ophthalmic vein, so SOV and IOV, drain to the cavernous sinus on either side. And then you have laterally, you have drainage into the sphenoparietal sinus, which pretty much drains the superficial sylvian vein. And then if there is, of course, a CC fistula, you can have reflux, retrograde reflux into those cortical veins, and they can go all the way back up to the superior sagittal sinus. And also you have some of those drainage going into the middle meningeal vein, and come from there into some of the deep veins, basal vein of Rosenthal, going to the vein of Galen, all the way to the straight sinus. And then if you look posteriorly, it's also the outlet of the cavernous sinus is drained by the superior petrosus sinus that goes straight into the junction of the transverse sinus and the sigmoid sinus. And then you have the inferior petrosus sinus draining directly into the internal jugular vein. So that's like an outlet. Some of them, and I should also say that in these sinuses, there's no valve. So there's no like, okay, it goes in this direction. But of course, you're having arterial flow into, drained by the vein all the way back into the tubular, into transverse sinus, through the sigmoid, all the way down to the IJV, back to the subclavian vein into the heart. But in this condition, there is change in dynamics, and there could be, flow could be forwards or backwards, and then can cause problems. We'll talk about them as we go along. Now, this next slide pretty much just gives you a quick pictorial view of where the area we're dealing with. This is the cavernous sinus we're dealing with on the right side and on the left. This is the cavernous segment of the carotid artery, just at this point, before it becomes intradural, where it breaks through the dural ring and then becomes intradural. So it's still extradural at this point. And then you have the basilar plexus. This is the sigmoid sinus. And of course, the transverse, so it all drains all the way to this, down to through the straight sinus, if it's going through the deep veins, or if it's going superficially through the superficial sinus, back to the tubular, and then through the transverse sinus, into the sigmoid sinus, and then goes through the jugular foramen and connects with the internal jugular vein. And of course, these are part of other sinuses, the occipital sinus, which is more prominent in children, the occipital or the marginal sinus. Now, on this side, this is actually the connection for patients that have direct CC fistulas. This is the ICA on this right side, and you see the way it connects directly to this cavernous sinus. And you see you have lots of trabeculae, lots of leaflets, and this forms the cavernous sinus. And it can be a big hole. In fact, before the advent of course, like we talked about, airbags and people wearing helmets and taking precautions, and of course, reduction in motor vehicle accidents, at least in this part of the world. When you do a diagnosis cerebral angiogram for a patient with CC fistula, it can be very dramatic. You're like, because once you have the arterial phase, the blood leaks into the cavernous sinus, pretty much engulfs all of the ICA and goes straight into the venous phase. So it looks quite dramatic when you see one. And we have pictures to show you as well. So this is, of course, the cavernous sinus, carotid artery, and of course, there's an intercavernous connection between the right and the left, anterior and posterior cavernous connection between right and left, and you can have things flowing from right cavernous sinus into the left as well. This is, of course, this is the superior petrosal sinus and inferior petrosal sinus as well, draining backwards. Now let's keep going. Now we see here that this is just a schematic diagram of the ICA. You have the cervical ICA, the petrous ICA, lateral segment, then goes into the posterior genu, anterior genu, and then becomes intradural. Now you find that, just to give you an idea of the anatomy I've talked about the cavernous sinus itself. Let's talk about your cavernous segment of the carotid artery itself. So this is, of course, a lateral angiogram of the ICA. This, of course, is your petrous segment. It's the mandibulovidian branch, which is, rare branches that can come from the petrous segment of the ICA. You can also have the stapedial branch coming out from here sometimes, and this could sometimes also contribute towards a cavernous carotid fistula as well. Then you have the cavernous segments, the posterior genu, where you have the meningo-hypophyseal trunk emanating and gives you those marginal tentorial branches and basilar tentorial branches that often contribute to CC fistula. Then, of course, just before you get to the anterior genu, you have the ILT, inferior trunk, which are branches of the cavernous segment of the ICA that often contribute to either direct fistulas or type A, or either indirect arteriovenous fistulas as well. And of course, it's at this point your ICA becomes intradural, and you have the first intradural segment of the ICA, which is the ophthalmic artery. This, of course, as you carry on, is a PCOM, posterior communicating artery, in the anterior choroidal, before it then comes to the terminal segment and divides into the MCA and ACA. This here is an AP, right ICA AP diagram, angiogram, showing a cavernous segment aneurysm. So you see the way this aneurysm protrudes into the cavernous segment, and then this can actually grow, rupture, and cause a CC fistula as well. So be mindful. All right, other pictures we want to show you here is this is an angiogram where there's been an injection of the vertebral artery, and you now see a retrograde opacification of this cavernous sinus, and you see this aneurysmal dilatation or aneurysm that is protruding into the cavernous sinus and filling the cavernous sinus as well. And this retrograde flow goes into the superior ophthalmic vein. And that is actually what causes that engorgement of the eye. It's the retrograde opacification or filling of the superior ophthalmic vein or inferior ophthalmic vein that causes that engorgement you see in the eye. And of course, when we'll talk about treatment, you need to coil off all the way into the cavernous segment to make sure you don't have a residual or remnant of your CC fistula. So if you're looking to see where is the exact location of the CC fistula, you need to do a 6-vessel angiogram. You need to do right side ICA, ECA, left side ICA, ECA. You also need to do the vertebral artery right and left. Sometimes you do one side, maybe the right side, and then you can have enough retrograde opacification of the opposite side where you see the pica. That's usually good enough, to be honest. Otherwise, you need to come over to the left side and do either a subclavian, run, or you can actually catheterize the left vertebral artery and do a direct injection as well. And this shows you that same picture we saw earlier on, which is this cavernous segment IC aneurysm on the right side, filling from a vertebral artery injection. This is the left vertebral artery all the way you'll see the basilar, terminates at the PCAs, the SCAs, supracerebellar artery, and then going retrograde through the PCOM and filling this cavernous segment ICA. And that's all because of that retrograde flow and change in dynamics because of the CC fistula. All right, we're progressing. Let's just quickly talk about the direct CC fistula itself. So direct CC fistula is a connection between the cavernous ICA, we talked about that, and veins of the cavernous sinus. It usually occurs in young males following trauma, and typically is a high flow lesion. Can occur, we said, due to facial trauma. It could be iatrogenic. You're doing a transphenoidal hypophysectomy, and you're not very careful, and you breach into the ICA. You can actually cause an iatrogenic CC fistula, where you cause a tear, neural tear within the ICA, and that you say, well, it's okay, you just put a bit of muscle and TCL. But you find that over time, that continues to leak into the cavernous sinus. So, of course, delayed imaging, follow-up imaging, if you're worried, needs to be considered. Now, classic symptoms in order of in one study, in other percentages, the most common we find is a loud bruit. 80%, 8 out of 10 patients will say they notice this, this sound, this thing in their head, machine-like sound, or rumbling sound or whooshing sound. Please don't refer them to the psychiatric hospital. We need to check and see what's going on. Proptosis, the eye bulging, of course, that brings it to the attention of everyone. They get to see our ophthalmology colleagues. Chemosis, the double vision because of the 6th nerve palsy. Remember the 3, 4, and 6 on the wall of the lateral of the cavernous sinus. So compression due to engorgement of the cavernous sinus can lead to cranial nerve palsies. Not just the 6th nerve, could involve the 3rd nerve. I had a patient with 3rd nerve palsy, was pupil sparing. The eyeball was down and out with the 6th nerve in the same patient. So it could be quite aggressive sometimes. Visual loss is what we worry about. And if it's progressive, of course, you don't want to wait until it's progressive. You want to deal with it if there are visual disturbances. Retroorbital pain is another thing. Cortical venous drainage. You find that not only does it drain into the cavernous sinus, it can go through the sphenoparietal sinus and reflux back, retrograde, of course, into the SOV, to the eye. It can go into the cortical veins, through the sylvian vein, superficial sylvian vein, or it can go through that, uncal veins, and then it can then drain into your basal vein of Rosenthal, all the way back, into the vein of Galen, and then into the straight sinus, and have deep venous drainage as well. And of course, because of the shear pressure gradient, that leads to venous hypertension, venous infarcts, intracranial hemorrhage, focal neurological deficits, and seizures. Sorry, just apologize. Somebody's trying to call me. Make sure. Okay, now we also find here that to make a diagnosis, you have basic non-invasive imaging. What can you do other than a cerebral angiogram? You can ask for a simple CT. And one giveaway is that you would notice that the cavernous is quite big. The cavernous region becomes quite busy. It's full, you're like, what's going on here? So this is not right, even just with just the regular eye. Then you can see, what also you can see is a dilated superior ophthalmic vein, quite large, either inferior ophthalmic or superior ophthalmic vein that, leads all the way to the eye that is proptosed and engorged and, distorted. So that's another giveaway. Then you progress. You've done a CT angiogram with contrast, or you can also progress and just do, a CTA, CT cerebral angiogram, with, fine cuts. Of course, you want the source imaging with all the cuts. You want to look at that properly. That usually also is a giveaway. Or an MR angiogram will also give an idea of that this is what's going on. Of course, but the gold standard, and of course, to be able to plan for treatments, you need to do a DSA, diagnostic cerebral angiogram, where 6-vessel, we can't overemphasize that. You need to do both ICAs, both ECAs on either side, and you want to visualize both vertebral arteries, either one refluxing to the other or doing both. These maneuvers, the Mehringer, Heichmer, and the Huber maneuver, just describe some things you can do while doing the angiogram. You can compress the ipsilateral common carotid artery while doing that ICA injection to slow down the flow, so you can actually see the point of the fistula, because everything just fills up with blood. You're like, where is the fistula exactly? Because you need to identify the fistula's point if you're going to progress with treatment, of course. Or you do Huber's maneuver, where you're still doing a common carotid artery compression while doing a vertebral artery injection, just to slow down the flow, to allow for you to see. Or you increase the frame rate, so that you can actually slow things and see, at what point the fistula is occurring. Or another trick to it is that you do a posterior circulatory injection, a vertebral artery injection, and then you look and see how it goes from the PCOM, posterior communication artery, goes all the way, vertebral artery, basal artery, goes to the PCA, goes to the PCOM, and there's a retrograde reflux, an opacification of the cavernous CC, the point of CC fistula, and you can see the top of it, where it dumps in, and you can actually help tell the upper margin of where your CC fistula is. Now, how do we get this treated? Usually, if it's a direct CC fistula, the preference is to go transarterial. All the times we've done treatments for CC fistula, we've always gone either transvenous, or we've done a direct puncture of the supraophthalmic vein and done a direct access that way. But transarterial, because there's a huge flow and it's dumping in, or you do a combined approach where you do a transarterial, put up a balloon, inflate the balloon to slow down the flow, come transvenous, go to the femoral artery, IVC, all the way up into the, all the way up to the internal jugular vein, and then you access the infrapetrosal sinus, and then we'll talk about it, and then that's where you can then get into the cavernous sinus and pack with coils. But of course, because of that high flow, you need a balloon to, not just because of the high flow, but the fact that the coils sometimes protrude back into the parent vessel, the ICA. You can't have that happening, of course. You're just going to give the person a stroke. You don't want your coils going from the cavernous sinus because of the huge hole into the ICA. So you put the balloon to protect you. Or other things, old school is where they use detachable latex or silicone balloon, and they will, get there, put it in a hole, inflate it, and then detach it. The problem with that is sometimes when they were tugging to detach the balloon from the device, what happened is the balloon pulled back and then embolized into the ICA, which you don't want to think about. That's bad, and goes straight away to the ICA. So that, of course, will give you a massive stroke on that side of the hemisphere. So that, of course, fell out of favor. I was in touch with my former boss, Charles Max, and he told me in the 80s, his boss, pretty much taught him how to do, when of course, endovascular procedures were not an in thing. What they will do is that they will do a craniotomy, as if you're going for like a aneurysmal clipping, maybe picoaneurysmal clipping, terminal craniotomy. Then they will isolate the ICA in the neck, get some muscle, crush it, put it in the syringe, open up the ICA, make an opening to it, and then before you do anything, clamp the introduced segment of the ICA from the craniotomy, then inject with a syringe the mashed muscle, all the way, and then sew up and then release the clamp. So what they're pretty much doing was sacrificing the ICA on that side, which is, of course, a modus of treatment. But we have the more elegant endovascular treatment, because that one, you don't know where things are going. You're hoping with the clamp you put, intradural segment of the ICA, that when you release your clamp, that muscle does not continue to embolize all the way up. So we don't do that anymore. Other options include using covered stents as a second line, or flow diverters in conjunction with coiling as well, or using liquid embolics, or standalone, which really we're yet to see what the results are there. All right, so just a few more pictures just to give you an idea what's going on. This is a cavernous carotid fistula following trauma. This is direct CC fistula. This is an injection. You're wondering what's going on here. This is your cavernous segment of the ICA. The cavernous side completely engulfed with the venous flow of blood from the ICA itself. You can see a retrograde filling of the supraophthalmic vein going to the eye. You can see there's deep venous drainage to the basal vein of Rosenthal, all the way back, flowing to the vein of Galen and then into the straight sinus. You can see retrograde opacification of all these cerebellar veins because of venous hypertension. It tells you this, this isn't going to go well over time. It's going to hemorrhage over time. This is the lateral, and that's the AP view. You can see there is also contralateral filling of the contralateral opposite cavernous sinus on the right side here. This is another CC fistula of another patient where you have this superior ophthalmic vein and inferior ophthalmic vein opacifying as a result of this direct CC fistula. You can see the posterior inferior drainage through the inferior petrosal sinus. You can see the deep venous drainage through the basal vein of Rosenthal into the straight sinus. Then you see the MCA branches. There's hardly, this is an ICA injection, a lateral ICA injection. There's hardly any flow in the middle cerebral artery branches. That's because all of the blood is dumping into the cavernous sinus and not going antegrade. It's just, there's a steal, as it were, a steal of blood from the antegrade flow into the cavernous sinus. And I don't know what I have it here, but after this was treated, you could see all the MCA branches become to good antegrade opacification of the MCA flow on that side, which was great for this patient. Some of these pictures, of course, we got from some of the texts which I have references made. Of course, this is the basal vessel. This is the AP view of this same patient. This is the basal vessel Rosenthal going all the way back into the straight sinus. Now here we see where in this patient with a left CC fistula, there's been a contralateral injection of the IC on the right side. You see clear, beautiful antegrade filling of the MCA territory, the A1, the A2, and the ACA territory, and there's a nice crossover on the opposite side and filling the left MCA territory, and there's a retrograde filling of the ICA up to the upper margin of where the direct CC fistula is identified. But you don't see at all, the left ICA. It's almost pretty much non-functional for this patient. So, as it were, this patient has pretty much passed, their, vessel sacrifice. If you were wondering, can you actually just sacrifice the left ICA and get on with it? You can, because there's good antegrade flow. Of course, there's no guarantee there won't be a stroke afterwards, but this is a good angiographic pass in terms of antegrade flow following a contralateral injection in a CC fistula. This is, of course, the supraophthalmic vein. This is a inferior petrosal sinus posteriorly. This is a pituitary gland that's being highlighted because of all that dumping of arterial blood into the cavernous sinus. And of course, this is a retrograde flow back into the superior ophthalmic vein, back into the eye. This is not MCA flow. This is actually retrograde venous opacification because of cortical venous reflux, because of the high gradient and venous hypertension. Here, you find there is a non-invasive imaging, an MRA showing this dilated, what looks like a right-sided cavernous segment IC aneurysm, a cavernous carotid aneurysm. This is the initial arterial injection showing the filling of that aneurysm into the cavernous sinus, and this is a later phase where you see all that reflux into the cavernous. This is the cavernous sinus, and all the way you can see some of the branches of the basal vein of Rosenthal going to the vein of Galen, or to the straight sinus and back to the tubular. This isn't very good, and of course, this is your retrograde flow to the superior ophthalmic vein. You see here, this has been treated. They put coils. This was pretty much here showing that the right ICA itself is is all dumping. If you did that injection, was dumping straight to the cavernous sinus, but the contralateral injection of the left ICA shows a good contralateral flow. So that means that if we sacrifice the right ICA, the patient will still have very good collateral filling from his right left-sided ICA itself. So in this patient, they opted to coil or trap, as it were, above the site of the fistula and below the site of fistula. Coils were put into the cavernous segment itself, filling the coils. And you see the coil coiled all the way to the cavernous segment and the petrous segment of the ICA on the right side. And this is the post-treatment angiogram showing there's still good antegrade collateral filling on both sides. So this is a good result. These are other pictures still showing you how there's a injection of the ICA, common carotid injection. You see the ECA branches, the ICA injection. There's a dissection here. You can see the irregularity in the ICA. And then all the way into the cavernous segment, we find the, what neural tear that you see this direct flow into the cavernous sinus. And you see the retrograde flow into the SOV, supraophthalmic vein. And this is where there's been a combined approach where they put a balloon up into the ICA because every time they tried to coil within the transvenously in the cavernous sinus, it was protruding into the ICA parent vessel. So this balloon was inflated while the coiling was going on, and you deflate, inflate, so you don't cause this, you don't keep it up for too long, the balloon for too long. This is the AP view, and this is the final run post-embolization view, showing good antegrade flow within the ICA and exclusion of the CC fistula on this side. All right, what about the indirect CC fistula? We're going to just speed things up, almost there. Remember we talked about the direct fistula being like a mural tear, like a hole within the ICA in the cavernous segment, dumping directly into the cavernous sinus on either side, depending on which side. But for this one, you have branches of the ICA or ECA, which contribute more of a true atriovenous fistula, where you have early venous opacification of the veins within that cavernous sinus, but it's not as dramatic as you see because it's not high flow. They're not usually very high flow as the direct fistula, because they're going through smaller branches of ICA or branches of the ECA. In this indirect cystic fistula, they are more common in women in the 60s and 70s. Sometimes spontaneous regression occurs when they are slow flowing indirect CC fistulas. We talked about the various classifications. B, C, D. B is when it's only branches of ICA. C is when it's branches of ECA, and D is when it's both ICA and ECA branches contributing to this indirect CC fistula. Symptoms, of course, are similar depending on the pattern of drainage, either going towards the eye through the SOV or retrograding to the corticovenous reflux, causing venous hypertension, can lead to hemorrhages or seizures, or even focal neurological deficits because of compression of the cranial nerves within the cavernous sinus. Same thing, standard angiogram, 6 vessel diagnostic angiogram. We talked about the pattern of drainage already. And then sometimes you can, if you think you do the initial angiogram, you think it's slow flow, there are not many vessels involved, you can attempt a conservative management if you think it's mild features on the diagnostic angiogram. Of course, you can only tell when you bring the patient back in 3 months or 6 months and repeat your diagnostic angiogram to see whether there is complete resolution. Because if it doesn't resolve, it's just going to get worse, of course. Or the patient can say, oh, my eye is protruding more, I'm hearing more of those noises. That can also be a clue that things are getting worse. In this regard, in terms of treatment of indirect CC fistula, we tend to come transvenous because the arterial branches are usually very small. You find it difficult to access them, and you come through the femoral vein all the way up, like we said, up into the internal jugular vein through the IPS, and then you can then gain access to the cavernous sinus. We haven't used liquids, we just use coils. Some of the cases we did in my fellowship, we had used about 40 coils. In one, we used about 35. And another one where my co-fellow was first assistant, they used about maybe 6 or 7 coils. In that case, it was just one tributary, I think it was just the meningoapophyseal trunk that was contributing to the indirect fistula. I think that was pretty much just the type B CC fistula that they were dealing with. So they didn't require, and we came through a different route. We'll talk about it. So can we mute this person? Can we mute this individual, please? Thank you very much. Appreciate it. All right. So in terms of access, to do I think we're going to get to it. So let me not jump the gun. Other ways, just as summarizing ways of treatment, will be gamma knife radiosurgery, especially for low flow fistulas. And then for gamma knife, it's been found in some studies that if you do a pre-radiological particle embolization, we use particles as to, just to slow things down. Particles are like shavings of plastic, and they come in various sizes. And you do that initially just to kind of slow down the flow a bit more before you give the gamma knife treatment. That's been found to improve the efficacy of gamma knife treatment for CC fistulas. This picture I have here just shows a patient that's self-resolved. Sorry, the picture quality. We see a lateral ICA injection with a cavernous segment CC fistula. You can see that filling the cavernous sinus. And then, of course, later phases, the venous phase, you can see a slow filling of the superior-ophthalmic vein, retrograde filling of superior-ophthalmic vein. This patient was brought back after a couple of months. I think it was like a month or so later. And at that point, you can see there's hardly any filling of the cavernous sinus, and there's no more opacification of the SOV. So yes, you can have spontaneous regression, especially for low-flow indirect CC fistulas. This also, apologize for the picture quality here from one of the texts. We see a indirect, I think this one was a type D indirect CC fistula where there was involvement of the ECA branches. You can see the ECA, the facial artery, lingual artery, the occipital artery, all the way up, and you have branches of both MMA and some of the ascending pharyngeal contributing towards the CC fistula, drainage through the inferior petrosal sinus posteriorly here. You also find that there's then the approach to treatment for this patient was where they put coils and they used onyx. This is the onyx glue that followed. They put the coils up here and then followed up with onyx glue. In my training, we haven't used glue as well. We just use coils completely, and it has worked very well. And this is a post-treatment angiogram as well, where there's no more filling of the cavernous sinus, fistula cavernous sinus. Now, just a little talk about, because I wrap this up, I can open up for conversation. A little talk about transvenous approach. Of course, the ipsilateral inferior petrosal sinus is the commonest access. So you come through the groin. So what we'll do is we'll typically have a catheter within, a sheath within the radial artery. So where we do our arterial runs, and then we can use it either as a roadmap or following treatment. We can see that the actual treatment has actually worked, or the fistulous filling is slowed down significantly. So you do that, do initial run, have your roadmap guide and all that. And then you go transvenously, you catheterize you puncture the femoral vein all the way up to the IVC, vena cava, all the way up into the internal jugular vein, through the subclavian vein, internal jugular vein. You're going retrograde, of course. So you're going all the way back up. And then you get into your inferior petrosal sinus from your internal jugular vein. That's the commonest route. If that doesn't work, that's when you begin to look at alternative routes. Alternative routes would look like you can try the superior ophthalmic, the superior petrosal sinus instead of the inferior petrosal sinus. Even when there's thrombosis, you can sometimes just twirl your micro wire and get that up. So you pretty place it like a 6-thread shuttle all the way up. Use your guide, either use a vert, just a regular vert catheter, using your wire, you'll get it all the way up, and then you can then, for a microcatheter, use a headway dual, 156, 167, whatever you have on shelf, and then with your micro wire, 014 wire, and then you access those small vessels, and then you keep twirling it till you get into the cavernous sinus. When you get to the cavernous sinus, then you want to at least get, as much as possible, start coiling from your superior ophthalmic vein, maybe midway through your superior ophthalmic vein, all the way backwards. Because if you coil from your IPS, you close access, you can't do anything more, and that's dangerous. You want to coil from the SOV backwards. And when you're coiling, you're making sure you're filling places like the sphenoparietal sinus, because if you leave that and you coil all the way back and there are holes, you would have made things worse. But what would happen is that you've coiled off, you think you've done a good job, but there's still direct access from the cavernous sinus into, the deep venous, drainage, and it goes in through the uncle veins into the basal vein horizontal, and that's terrible. And now you've closed your access. You can't do that anymore. So that's so we need to be very careful while coiling. So you see some of that venous lake engulfing your ICA posteriorly, anteriorly. You want to coil off all those pockets, because the cavernous sinus itself comes in pockets that trabeculate. So you want to fill all the pockets as you go. And that's why this is the treatment that takes the most amount of coils. You can use up 40 coils very easily in one, and that's why it makes it very expensive in terms of treatment. Other routes, which I haven't been privileged to be part of, is direct puncture of the cavernous sinus using a fluoroscopic guidance. I think our older bosses, Professor Moran and so on, would have used this kind of technique. Or in Minnesota, what we did was, for this patient, it was a direct, we got the ophthalmic surgeon to do a puncture of the SOV for us, and then we put a microcatheter into the supraophthalmic vein, and we're able to run, situate you send the micro wire into the cavernous sinus, and then that way you then coil, all the way this way. So you're sort of coiling, because you're not coming from your venous, you're coming from SOV. So you now have to go all the way into you start from the outflow of your IPS, inferior protrusive sinus, and then coil all the way into the SOV, and then you stop. So that's direct puncture. And of course, you're very careful, because if you lose access, you can cause intraorbital hematoma and blindness. Fortunately, that case went very well. This, of course, is what we'll be talking about. This is a patient with a vertebral artery injection. You see all the vertebral artery becomes intradural, the V4 segment, basal artery, PCA. See all the branch of the PCA. This is posterior fossa on this side, of course, supplying the cerebellum. And then you have the PCOM, posterior communicating artery, that then have a retrograde flow into the cavernous sinus and then into the SOV, superior ophthalmic vein, filling, the eyeball. And you can see the facial vein draining. And that also could be an access point for us, transvenous access point to coiling, to getting into to treating CC fistula if peradventure you can't access your inferior protrusive sinus. And we've used this particular common facial vein going all the way into the angular vein into the SOV, and then you then call from here backwards all the way. Of course, from the cavernous sinus outflow all the way into the SOV halfway, and you stop. Now, this is the orbital team, having that controlling the access of the SOV, which is engorged, and then we're able to puncture that and put our microcatheter in and see the beautiful cosmetic result at the end. All right, I think I have one more slide left to go. Outcomes. So how do patients do? Especially for indirect CC fistulas, it's been 80 to 90% in recent literature, complete fistula obliteration after single endovascular treatment. Symptoms related to the increased intraocular pressure typically resolve first. The eye engorgement resolves, and all that, ophthalmoplegia begins to improve, the vision begins to improve, because that retrograde flow into the supraophthalmic vein has been disconnected. Paradoxically, some patients get worse before they get better. And the reason for that sometimes is because you're packing the cavernous sinus. And for our patients, we'll put them on dexamethasone, 4 milligrams of dexamethasone, maybe TID, and then you slow wean over a week because of the sheer compression of the coils within the cavernous sinus. And those cranial nerves 3, 4, and 6 are just on the wall, lateral wall. So you can have some cranial neuropathies that persist despite treatment. Of course, you want to wrap up. We want to wrap up with just this particular flow diagram, which I found very useful from one of the texts. You see, you suspect a CC fistula. Hopefully, they don't present to the psychiatrist, or they don't present, to people who think it's all normal. You do a non-invasive imaging, a CT scan with contrasts, with or without contrast. You get an MRA, a CTA. You then refer them for a 6-vessel diagnostic gold standard angiogram. You then classify whether it's a direct CC fistula. Sometimes the etiology will tell you what it is, a direct CC fistula. If it's direct, where there's direct a mural tear within the ICA going to the cavernous sinus, you want to favor a transarterial access or a combined transarterial using a balloon, and then you coil from a transvenous approach using coils or liquid embolics like an onyx, to follow after. Second line is using covered stents or flow diverters alongside coiling, of course. Then if it's an indirect fistula, that type B, C, D, if it's mild, low flow, you can watch, you can observe. Don't be trigger happy. You can bring them back after 3 months, repeat the angiogram, or in 6 months. Or if it's severe or symptom progressed, or on follow-up imaging, it looks as it's not closing, or it's getting worse, so there's now cortical venous reflux, showing that it's, of course, it's high flow, and there's now increasing pressure gradient. Then you want to come transvenously, which is favored, and coil. We've talked about the various accesses, or low flow. Think about gamma knife. Gamma knife access with initial using particle embolization just before delivering gamma knife to that patient. So this is a quick idea. If you're wondering, how do I go? What do I do? Which direction do I go? This is some sort of guide. References, apart from the cases we did, were from, I've showed you the pictures, I didn't save some of those pictures, were from Yeoman's, as well as the textbook, which is all you need for basic diagnosis cerebral angiogram, practical neuroangiography by P.S. Morris. So thank you very much. I'll stop here. I want to make sure we give time for a conversation. Feel free to get in touch. We apologize once again that Dr. Jagadisan could not be here, but I was hopeful. I hope that we did gain something today. Back to Dr. Bankole. Dr. Bankole, are you muted?
All right, thank you very much, Dr. Kafo, for the presentation. I'm just going to look through the chat for the. All right, so they have one question here. Dr. Kafo, could you explain the types of indirect CCF? The person missed that part. I think you had already explained, but maybe you could just go over that briefly.
Okay, thank you for that question. CC fistulas are classified into two, direct or indirect. Direct, usually secondary to trauma. There's a big hole, transmural tear within the ICA, cavernous segment of the ICA, and it's pretty much dumping blood, almost like a steel of blood into the cavernous sinus, usually high flow. And doesn't involve any other vessels, either the ICA itself or some of its branches, either MHT or ILT. For indirect, it's more of a true dural fistula. They're usually not as high flow. They're usually more low flow fistulas. Some of them can even resolve on their own spontaneously sometimes on follow-up. And in these ones, you then classify them into type B, C, and D. B is when it's only branches of the ICA that are involved. The ILT, MHT, some of the branches of the ICA, Madublovidian branch or something, giving some kind of contribution. And it connects with usually the meningeal leaflets within the cavernous sinus. So that's type B, only ICA branches. Type C is when it's ECA, so external carotid artery. Some of the ascending pharyngeal branches, contribution from the ascending pharyngeal artery, either from the superior pharyngeal branch or the neuromedullary trunk, giving some meningeal contributions through some of the foramen and the skull base, connecting with the cavernous sinus, or there's early filling of cavernous. You do the angiogram and you notice the cavernous is already filling in the arterial phase. So you know there's a fistula, but in the cavernous segment. So only ECA branches. And then lastly, type D is when both ICA and ECA branches also contribute to that indirect true arteriovenous fistula in the cavernous region. So I hope I didn't confuse you more, but hopefully with the pictures you saw, these are the ways. So in that case, you are treating transvenously, and sometimes you can even come up through some of those, if there's still some filling, can come up through the ECA and embolize that way as well.
All right, thank you very much. So, okay. We have one of our very, very senior ophthalmology professors with us. She's joined from the beginning, and I've asked her to just kindly make a comment on her experience with this, because this is not something personally in my practice. I think I've seen maybe, I don't know, maybe one or two, but we don't usually get to see them. So Professor Akishola is a very senior colleague and also currently the Dean, the Faculty of Clinical Sciences at the College of Medicine. Prof. Ma, if you can just share a few words concerning this and maybe what's been done in times past in our local environment.
Thank you very much, Professor Bankole. I appreciate Dr. Kafo. Well done. And I've enjoyed myself thoroughly, and in particular, the aggressive eye that you showed initially, and the one at the end where you actually went through the superior orbital area for the clipping of the fistula. Yes, as he has said, we don't get to see this aggressive type. Maybe, as I can remember, maybe one or two from trauma. What we see mostly is cavernous carotid embolism or thrombosis. That's what we see mostly. And most of the time, it's more of a conservative medical treatment. Yes, I remember I've seen one, which are maybe low-grade kind of fistula with bruit, but also we manage that also conservatively. So the surgical aspect, well, that you have described is actually very enlightening, and I've enjoyed myself thoroughly, and I've learned quite a lot. So it's mostly because we see most of the infected carotid cavernous thrombosis due to one, sinusitis or some of the rhinitis, and also when you have periorbital boils. Those are the cases that we have seen in the past. So that's what I can talk about right now. Very much.
Thank you very much, man. I appreciate that insight. Yes, that's true. We do see a number of thrombosis, like you mentioned. But I think the fistula as well, we didn't have the options of treating them. So obviously everything is conservative. The value of the collaboration we're trying to develop is to hopefully have some of these endovascular options now available internationally to become domiciled within the country. And then hopefully we'll be able to address them when they do occur. Thank you, ma'am.
Yes, that would be lovely. Thank you very much for having me.
There's another question. It says, what is the extent of effect parking that high number of calls would have on the cranial nerves? Yeah, so what's the extent of the parking of the high number of calls on the cranial nerves to the extraocular muscles post-operatively? So I don't know, Dr. Kafo, if you can speak to that.
Okay.
Is there a number that can then damage the cranial nerve or affect the motility of the extraocular muscles?
Well, I just want to start by saying that the ophthalmoplegia you have is as a result of the pressure gradient from the CC fistula going retrograde through the supraophthalmic vein or the supraophthalmic vein to the eye, and of course causing engorgement, and that's causing your ophthalmoplegia and affecting eye movement. But when you're going to treat, you need to completely cover the fistula. You can't leave anything, because if you do, what will happen is that you cover the inlets from the SOV, which of course is having retrograde drainage, or you cover the outlet, which is from the inferior petrosal sinus or superior petrosal sinuses, and then you leave some spaces because you want to save on coils or you don't have enough. It's better you are ready to treat the patient with enough coils, or you don't do it at all. Because if it's a one-stop shop, when you go in, you have pretty much coiled off your access, so you can't get back in there. So you need to do it and do it well. You want to fill all that all the trabeculae of the cavernous sinus, you want to fill it up completely with coils until there's no more flow, or there's very trickle flow, very slow flow, early venous drainage into the cavernous sinus when you've done your post-transarterial angiogram, to be sure you're packing tight enough. Of course, the downside is that there are diseased cranial nerves on the wall, but you can just place the patient on dexamethasone. And usually a winning dose every week usually takes care of that. And to be honest, we still saw some in the presentation at 11% of patients that they still have persistent problems with eye movement despite the treatment. But yes, you do not want to leave any spaces, because what would then happen is you trap yourself both forward and backwards, and then on the inside, you are having continuous corticovenous reflux, or you're draining back into you're doing deep venous drainage. I can continue to increase your venous hypertension. You've done yourself, you're worse off than you started. So you want to make sure you have enough coils. And then treat with dexamethasone, and that takes care of the cranial nerve problems.
All right, thank you very much. There's somebody's hand up. I think we'll take that as the last one so that we don't run out of time.
I apologize. Just before we take the last question, there was someone that sent a referral. Dr. Okpara, do you want to speak, or do you have slides, or I don't know where time is gone?
Yeah, thank you so much, Dr. Okafor. Yes, I can still speak. I think I can make it in less than 5 minutes.
Okay, we don't have 5 minutes, but we're gonna try. All right.
It will be less than that.
Okay. Do you want to share, or do you want to just talk through? What do you want to do?
Okay, let me share.
Okay. You have access, right? Sorry, Dr. Bankole. Dr. Okpara has a current patient with, I think, a direct CC fistula.
That's interesting. I think that's
it's not as far-fetched than we think. Just that it's not being diagnosed. Go ahead.
Okay. I don't know if we can see my screen.
We can.
Let me see now. Okay, great. All right, so I'll just run through very quickly. Thank you very much for the opportunity, Dr. Okafor and Professor Bankole, and good day to the audience. I have this 18-year-old young man who presented to my clinic here in Owerri with a history of swelling over the left eye for over 15 months before presentation. And he had a prior history of trauma 3 months before onset of symptoms. And he was in a fight with a colleague, and the colleague had hit him on the left side of the face 3 months before onset of symptoms. When he presented to us, he had a leftosis, swelling on the left periorbital region that was painless, pulsatile, and with a brim. The left eye was displaced down and out, but there was no chemosis. He could still see with the eye, and there were normal eye movements. He came with a CT scan, and as you can see in the image, he has a very tortuous superior ophthalmic vein. I don't know if I can use something to highlight it, but that is it there, the superior ophthalmic vein. And there was
the left side.
Yes, on the left side, left-sided carotid cavernous fistula. We asked for magnetic resonance imaging with MRA, and let me see if I can play the, yes, that is it. So essentially the same findings. You can see the left-sided internal carotid artery there, and you can see where it gets into the cavernous sinus and how dilated the cavernous sinus is on the left side. You can see that. So this is where we're at. I shared these images with Dr. Okafor, and we think it's a direct cavernous fistula. He needs to have a 6-vessel digital subtraction angiography. And then we have counseled him for a therapeutic endovascular approach. He's been placed on antiplatelet therapy. And what is limiting him now is funds. So the reason for sharing this is just to say that we can have, I mean, this could present to you in your clinic at any time. It may be rare, but you never can tell when it will show up in your clinic. And it is very important for us to have the skills so that we can help our patients whenever they come in. Thank you.
Thank you very much, Dr. Okpara.
Thank you, Dr.
All
Okpara.
right, so that's the end of the show.
All right, I think you made it in less than 5. There's someone whose hand is up for a question, but I don't know. So, Dr. Okpara, do you want to speak to that slide? The slide
Yes.
that.
So you could see that the significant engorgement of the left superior ophthalmic vein, and of course with the history itself and the way
Very classic.
Very classic direct CC fistula, and it's getting worse for this young man. What we've tried to do is to see, could we get him onto Tekle, who of course was our last speaker. But the problem is funds. These coils are costly. Tekle is willing to do it for free in terms of no, he won't take any fee for his treatment, but the young man does not have enough money. And we're trying to see what ways we can, how funds can be raised. To be honest, this can be done back home in Nigeria with us. And I want to just take this opportunity to plead with us. We need to get a biplane new angiography suite running in Louth. Or some will say, well, bring it to my center. The truth is, we need to start training our own people. We can do this thing. Lots of people have lots of money. They don't know what to do with it. Please help us. Let's reach out to Dr. Banko. Let's reach out to ourselves, the West African Stroke Initiative. We really want to start getting these things done locally. We need a biplane. You can't do this just with a monoplaner because of the risks involved with just a single plane. You can do a few things with that, but this needs a biplane. So just speaking to us, you can help this young man. Please reach out to Dr. Okpara, who's the consultant dealing with this. We can do some fundraising for him, try and get him to Tekle, who is close by there in Africa to get the treatment done. And we can try and get a biplane machine. Start treating our own patients. We're big enough, Nigeria, we're big enough. And start training our own surgeons to do the procedure. Thank you.
All right, thank you very much, Dr. Okpara. Quickly, Dr.
Thank
Ayeni's hand has been up for a while. Dr. Ayeni, can you unmute and just ask your question? Dr. Ayeni, do you still have a question that you want to ask?
Your hand is still raised. Dr. Wenga.
Yeah.
What about mute?
Okay, in the main, while we wait for that, if it's still around, it says there's another question on the chat box. It's with the prevalence of conservative management in the country, what are the indications for immediate treatment / intervention, and what else can be done with the lack of endovascular intervention? I think that's been addressed. Not much else can be done. I don't think approaching it directly is what either the risk or will yield any significant benefit. The interventions, the indications remain the same everywhere. It's just whether you can intervene or not. So a case in point is the patient has just been presented. There are clear reasons to intervene, but the limitations to intervene include lack of funds and lack of facilities. Okay, somebody trying to speak.
Hello,
okay,
sir.
Dr. Yes, we can hear you. Go ahead.
Yes, sir. Thank you, sir, for the presentation. I just want to ask something that for the management, I wouldn't know if the prognosis of pure medication, just uses of drugs in the treatment, I want to know the prognosis. Is it better than any operation, or what's the percentage of pure medication in such case? Please, thank you. I'm talking of the management of carotid cavernous fistula. Okay. What's the prognosis of pure medication? That the person just want to use drugs? Please, sir. Thank you.
Thank you for that question, Dr. Yanni. Drugs have no place in the treatment. It's either you go with conservative management for an indirect fistula, but of course you want to, when you say conservative, as you're not doing anything, is that you are following up with imaging. And imaging is a diagnostic cerebral angiogram to document that there's been an angiographic occlusion of your fistula. So symptoms might improve, but that's not good enough. You need an angiographic documentation that there's no more fistulous flow. When I think Dr. Oba talked about putting the patient on dual antiplatelet therapy, that's actually in preparation for his treatment. So if you're going to do any endovascular treatment procedure, patient needs to be on dual antiplatelet therapy for at least a week or 10 days before the procedure. Because remember, we have to heparinize the patient, and we need to make sure that the risk of thrombosis and stroke is there. So using our devices, our catheters, these are thrombogenic material. So you give those medications just to kind of prevent the risk of stroke. And of course, in cases where you do an ICA, you sacrifice the ICA completely, the intercoronary artery. Sometimes there's stump emboli, and you need to put patients on either antiplatelet therapy or you think about it a bit more so that you avoid a stroke down the line. So there's no place for giving medication. In fact, giving antiplatelet therapy keeps the fistula open, actually. So you might be doing worse than you think, especially if there's no plan to get definitive treatment done with coiling or using liquid embolics, or for indirect, for not this young man, 18-year-old, because the direct fistula is high flow. You can't use radiotherapy. So the patient, we need to get the patient treated. It's treatable. If you do not treat, patient will end up with persistent venous hypertension, a venous hemorrhage, catastrophic hemorrhage, and death. But this is treatable. I hope that helps.
Okay, thank you very much, Dr. Kafo. I think we have exceeded our time a bit. But thank you. It's been an interesting presentation, and the questions and interactions have been well worth it. So we'd just like to inform us that the next round will take place 12th of June. Interestingly, we seem to have had the last two grand rounds have taken place on auspicious days. The last one before this was on February 14th, and this one seems to be on Eid al-Fitr, at least for those of us here in Nigeria, so it's public holiday as well. But so the 12th of June will be that, and the topic is as shown on the slide, on the flyer being shared. Please take note of the dates and feel free to invite your colleagues. We'll be delving a little bit more detail into the anatomy of the vessels. I've had, and this is very, very crucial and interesting, especially if one is preparing to be involved in this kind of treatment. The recordings for today's presentation is available on the YouTube channel, and there's a link on the channel in the chat box. So thank you very much for joining us again. And we hope the session has been valuable to you. Have a wonderful rest of the day. Thank you so much. Thank you, Dr. Kafu, for stepping in.
Thank you.
Thank you, Dr. Akushala. Thank you so much.
Thank you.
Thank you, Prof.
Thank you, very
Everyone.
Thank you. Thank you, Dr. Kafo.